Good evening. Welcome you all young Turk for this youth empowerment program. You know this program is to inspire all young Turks less than 45 years. So we are doing this program every second and last Friday 8 to 9 p.m. And we are taking general club mentoring sessions. We have done the mentoring about research and publications, ASHRAE certification for clinician, ASHRAE certification for embryology publications. And now we are going to start debates also, interjournal debates. So we will, from this month end, we'll take debates also. And special recognition will be given to the person who has win the debate. So it's our pleasure to invite expert for the today, Dr. Sonia Malik ma'am. Saranya, please show her CV.
Yes, ma'am.
Ma'am is Thanks, ma'am, for accepting the invitation.
She is
First
a
slide,
part
Dr.
of my
Sonia, ma'am,
slide.
slides.
It's a
I'm not able to share because
Rahul
another
has
sharing is there.
Rahul, you need to share that. Rahul, can you please kindly share?
Yes,
No,
ma'am.
Rahul, you can take out. Saranya has made all the PPTs.
Okay.
She will do. She has set everything. So thank you, ma'am, for accepting the invitation. Everyone will definitely be benefit with your inputs.
You don't have to
Yeah.
say that. IFS is a part of me. We are all together in this. So
Ma'am.
it's really nothing that I'm
Ma'am
doing.
needs actually no introduction. Ma'am is the
There's no
past
introduction.
president
Yes.
for the IFS. Yeah. So ma'am is the past president, Indian Fertility Society. She is the chair advocacy committee from 2018 till date. Past chair infertility committee, FOXY, past president, IFS, past president, Indian Menopausal Society, chair infertility committee, AOGD, Vice
Chal.
President, IMS South Delhi, Indian representative to International Menopause Society, Associate Editor of the South Asia Journal of Global Health, IFFS, member of the Editorial Board, Fertility and Sterility of India, past Editor-in-Chief Journal of Midlife Health, various teaching and training program ma'am is conducting, MIT IFS Fellowship, ICOG certification, Fellowship in Reproductive Medicine, more than 1,000 invited lecture, published first Indian guideline on PCOS management, published in international and national peer review journal, authorized to books and various awards, IMA Connect Coil, IMA Lifetime. So thank you very much, ma'am.
Thank you, Neeru. Thank you so much for having me here. I'm really, really thankful to all you girls for giving me this honor and for remembering me. Thank you so much. Thank you so much for giving me this opportunity to be here amongst the youngsters of IFS. You know, it is really
Yeah.
heartening to see
Yeah.
all these groups functioning so well and doing so well. So therefore,
These are our future of the
it
IFS.
is the future of IFS. Absolutely.
Yeah.
Absolutely. Thank you so much.
Yeah, ma'am, please stay till we have to ask so
Yes.
many questions and so many
Sure,
queries of
sure,
everything.
sure.
Yeah. So next slide, please, Saranya. Yeah. So still, if no one, anybody is still not the member of the IFS, please become the member of IFS. It hardly 2 minutes job online. You can register and become the member. Next slide. Various benefits. Your free access to IFS Genuine Junctional Quiz, Patient Empowerment Program, Intelligent Empowerment Program, Young Empowerment Program, Counselor Empowerment Program, Nurses Empowerment Program, and Self-Empowerment Program. So all you can enjoy by joining this. You have free access to everything. Next slide. So everyone who has still not registered for Fertivision, we are having our national conference, 20th National Conference, 6th, 7th, and 8th December at Gujarat, Ahmedabad. So you all can register for this conference. Next. Yeah. So today presenter is Dr. Saranya with us. She is a final year senior resident in Jipmer, Pondicherry. So welcome, Saranya. So now
Thank
you
you.
can take all dice is yours.
My slides visible, ma'am?
Yeah.
Okay. So good evening to everyone. And it's a privilege to be presenting here in front of Madam Dr. Sonia Malik. I'm thankful for this opportunity. So today I'm going to be presenting on this journal club an article from the journal Fertility and Sterility. Okay, so this is from the journal Fertility and Sterility, which is the official journal of the American Society of Reproductive Medicine, with an impact factor of 6.6 according to 2023. So today's topic is a diagnosis of diminished ovarian reserve does not impact embryo aneuploidy or live birth rates compared to patients with normal ovarian reserve. This study was done in Boston IVF, Waltham, Massachusetts. It is published in the journal as mentioned, Fertility and Sterility in volume 118, number 3 in September 2022. So why this topic or why this article is because a diagnosis of diminished ovarian reserve does not necessarily impact embryo aneuploidy or live birth rates compared to patients with normal ovarian reserve is what the study has shown. But because of so many conflicting results that has been published in the past in various articles or journals, there has been a doubt. So let's first understand what a diminished ovarian reserve means. It is an antral follicle count of less than 5 to 7 follicles or an AMH of less than 1.1 nanogram per ml. And poor ovarian response means poor ovarian response to ovarian stimulation, which denotes a reduction in the follicular response, resulting in a reduced number of retrieved oocytes. So there is a lot of doubt, like does the poor reproductive outcome result because of reduced ovarian response or because of additional qualitative oocyte morbidity, and also that if patients with diminished ovarian reserve will end up having good live births or not. So the embryonic aneuploidy results from several types of chromosomal segregation errors and affects higher number of human conceptions, resulting in infertility, miscarriages, and congenital disorders. So segregation errors have a direct predisposition to age and also impacts human reproductive lifespan. The factors being age, chromosomal oocyte errors, and ovarian response, they're all intertwined. So it remains unclear whether a premature reduction of ovarian reserve in younger patients is associated with preferential reduction in oocyte quality and increased embryo aneuploidy rates also. So patient counseling in those patients with diminished ovarian reserve is lacking evidence with respect to the variability in pre-cycle ovarian markers with respect to AMH, antral follicular count, and which indirectly affects the aneuploidy rates. So this lack of clarity could be aided by improved methods to define clearer comparative group and to avoid confounding by significant age differences. Propensity score methods preserve the study base by allowing more cases to be allowed and therefore avoid selection bias. So what is this propensity score method? It is a way to analyze the observational studies and also to minimize the exchangeability of groups in the experimental studies. So this reduces the effects of confounding factors due to measured baseline variables. So main objectives of this study is to estimate the aneuploidy rates in young women with diminished ovarian reserve before treatment and poor ovarian response post-retrieval. So and also to determine the live birth rates per euploid embryo transferred when women with diminished ovarian reserve or poor ovarian response to stimulation. Coming to the study design, it's a retrospective cohort study which was done in Boston IVF, Waltham, Massachusetts, which is an academically affiliated fertility clinic. The study duration was from December 2014 to December 2020. The participants of the study were women under 40 years of age who underwent IVF and also the first cycle of oocyte retrieval in the study period and who were planned for pre-implantation genetic testing for aneuploidy. Couples with no infertility diagnosis, according to the Society of Assisted Reproductive Technology report, categories were excluded. Coming to the procedure, women less than or equal to 40 years who were diagnosed with diminished ovarian reserve were included in the study. And two comparisons were made to assess aneuploidy in these patients. The first analysis, diminished ovarian reserve assigned by the fertility experts in the pre-cycle assessment by antral follicular count, follicle stimulating hormone, and AMH was done. An AMH cutoff was 1.1 nanogram per ml for the diminished ovarian reserve. A second analysis were a comparison between patients with poor ovarian response during ovarian stimulation, a refresh IVF cycle, defined as the cohort of patients with less than 5 retrieved oocytes in the study group, and also a POR control group of more than or equal to 5 oocytes. All the patients underwent ovarian stimulation, oocyte retrieval, and embryo transfer following all the standard protocols. The trigger used was either human gonadotropin or luprudil acetate or a combination of both. Most underwent conventional insemination, around 34% of the cycles using intracytoplasmic sperm injection. Luteal support by either vaginal or intramuscular route was given in form of progesterone supplementation. Pre-implantation genetic testing for aneuploidy screening was performed on all embryos between stages 3 and 6 using next generation sequencing. So the outcomes coming to the outcomes measure, the outcomes measured with the primary being aneuploid rate. So number of genetically unbalanced blastocysts divided by the total number of blastocysts biopsy in one treatment cycle. The other outcomes of interest included embryo transfer, the number of embryos transferred, clinical pregnancies, ectopic pregnancies, biochemical pregnancies, miscarriages, and live births. There was also an additional outcome, that is the rate of no euploid for transfers when all the embryos from a single oocyte retrieval were aneuploid. So the statistical analysis, the propensity score matching was done to adjust for confounders related to aneuploidy. The factors included with both demographic and clinical available to the IVF provider before the cycle. The factors were age, the body mass index of the patient, and the year of cycle initiation. Statistical analysis were performed using the R statistical software. Continuous data were analyzed with student research or man-Whitney tests for normally or non-normally distributed data. And categorical variables were analyzed with Fisher's extract test. All the tests were two-sided and p-value of less than 0.05 was considered significant. Propensity score analysis was done. The results, the original cohort included a total number of 2,219 patients who were less than 40 years of age in their first IVF cycle, of which 383 patients were diagnosed with diminished ovarian reserve and 143 with poor ovarian response. The first two comparisons were made, in which the first comparison consisted of patients with and without diminished ovarian reserve. They were matched in a 1:2 ratio, with 764 women with a non-diminished ovarian reserve as controls for 383 patients with diminished ovarian reserve. So before applying propensity score matching, the aneuploidy rate in a given stimulation cycle between the DOR and non-DOR group was 42% and 39% respectively. But the aneuploidy rate in a given stimulation cycle did not differ significantly between DOR and non-DOR group after applying propensity score matching. So it is seen that mean gonadotropin levels used was significantly more for the DOR group than the non-DOR group, and also the average ovarian test markers were 0.9 compared to 3.9 in non-DOR group, and according with respect to AFC was 10.3 compared to the non-DOR group. And there was a significantly more oocytes retrieved in the non-DOR group than the DOR group. For the second comparison of poor ovarian response versus non-poor ovarian response group, and 1:4 ratio was used, resulting in 143 and 572 patients with POR and without POR respectively. So it is seen the higher mean number of blastocysts were available for biopsy in POR group than the non-POR group, and also fertilization rates were lower in the POR group. But whereas the aneuploidy rates in a given stimulation cycle between the groups did not differ significantly. So this flowchart shows the aneuploidy rates of the matched cohorts with respect to the AMH levels. Here we can see the AMH percentile in the x-axis with aneuploidy rates depicted in the y-axis. The box plot shows the aneuploidy rate for each percentile of AMH. So we see that the aneuploidy rates did not differ significantly between all the three groups in different percentile levels of AMH. So coming to the outcomes after a single euploid embryo transfer, we see that the number of women with no euploid embryos to transfer differed significantly between the diminished ovarian reserve and poor ovarian response group with their respective controls. So we can see that 19.3% of the diminished ovarian reserve patients had no euploid embryos compared to the control of around 10.3%. And in poor ovarian reserve group, contrast to the 26.5% patients with no euploid embryos to transfer in POR with a control of 13.2%. So coming to the discussion, aneuploidy rates of blastocysts for women with DOR or POR, that is a diminished ovarian reserve that was seen before the cycle, that was categorized before beginning of the cycle, and also poor ovarian response that was seen post stimulation did not have an increased risk of aneuploidy compared with women with normal ovarian reserve and response respectively. Also, depletion of the follicular reserve in women less than 40 years is not associated with a concurrent increase in the fraction of embryos deemed aneuploid by the pre-gestational testing. And also, patients diagnosed with diminished ovarian reserve in blastocyst stage, the chances of having a euploid embryo is similar to that of the general infertile population. Patient information and reassurance is a must. It just signifies that it is a must to duly inform the patients that cycles without euploid embryo transfer is because of the lower ovarian response and has nothing to do with the qualitative reduction. And also, an increased rate of the no euploid embryos to transfer among the DOR and POR group may be because of the overall reduction in the developing embryos in these groups and is not significantly associated with the qualitative reduction of these embryos. So, strengths of the study being the use of propensity score matching to minimize confounding, and also a large data set and uniform use of next generation sequencing to perform PGT. Limitations is the retrospective study, wherein large data collection over a long period of time, because of the major shifts in one group compared to the control in the study group, might have limited the fertility outcomes. Also, the exclusion of cycles without viable blastocysts may bias results. Coming to the conclusion, diminished ovarian reserve patients undergoing the first IVF cycle and those recognized as poor responders to ovarian stimulation show a similar rate of aneuploidy blastocysts compared with women with a standard ovarian reserve and response respectively. So when a euploid embryo is transferred, its developmental potential to achieve a birth is not impacted by the DOR or POR of diagnosis. A low pre-cycle AMH and AFC levels and ovarian response parameters were not associated with increased aneuploidy rates. Also, this data could be used to individualize patient counseling regarding the prognosis of IVF in diminished ovarian reserve patients. Thank you.
Thank you. So thank you, Dr. Saranya.
Thank you.
Thank you.
Yeah, ma'am.
Yeah.
You would like
So
to
thank you,
give any-
Dr. Saranya. Thank you very much. Very well presented.
Thank
Very
you,
well
ma'am.
presented. And, you have been able to convey what you wanted to. Just a couple of questions, just to tell us, basically we are belonging to a different ethnicity. And first of all, the number of DOR patients that they had was much less as compared to what we are getting now in our clinics. It is much more, and therefore we need to understand this paper very well, because if it says that the aneuploidy rate was the same, then we have some kind of a solace for our patients. Only thing is, if you can go back to your chart and tell us what the age of the patient, what was the mean age of these patients, DOR and non-DOR? Yeah. Again, diminished ovarian reserve, they have said that AFC less than 5 to 7 follicles. Whereas according to the, Poseidon criteria, we have, it is from 4 to 9. Hyper-response is up to 9. And below that, below 4 is poor responder, no? So basically, you have this paper has clubbed it into diminished ovarian reserve rather than categorizing into hypo and poor. Okay, because here, if you see over here, age, okay, let us take the
Yes,
age.
ma'am.
Age is the same, 36
Yes.
years. So in our population, 36, we may still have a lot of DOR. Here too, they have the mean age is the same, and the AMH level is pretty good in the non-DOR, 3.9, as against 0.9 here. AFC also is 6.4 and 10.3. Total gonadotrophin used is definitely less in the non-DOR group, and oocytes retrieved were showing a very big difference, right? But again, like I said, the mean number of oocytes retrieved are 9, So if we were to classify it according to the Poseidon, this would have been a hypo response, okay? And aneuploidy, of course, go on to the next one. I have to actually read what propensity score means. I really do not know what that is. Again here, this is according to the ratio, the second part of the comparison, which is extremely good. You have fertilization rate in these patients, non-POR was much better. Blastocyst biopsy were also better. Aneuploidy was the same, right?
Yes, ma'am.
Again, now here there is hardly any difference in the FSH was on the higher side, 9 in POR group, and in that one it was 7. And what else was I seeing? AMH was also different, yeah. And AFC was 6 against 10. Okay, so basically just that the definition that you have used is different, but otherwise they are trying to assess the same things as the Poseidon group did. Okay, so I think by and large it is giving us an insight into the genetics of these embryos, which means, see, the only question is whether 36 is a good cutoff for our patients or not, Neeru. Because I don't think, we will get so many embryos and so many to biopsy in this group of patients where you have a poor DOR, a poor or a diminished ovarian reserve. And they, in a younger patient, maybe 32 years, you may have the similar number of blastocysts as far as euploidy is concerned. Whether it is, the DOR group, huh?
Ma'am, can I say something?
Yeah.
Ma'am, I think that because we know that the reason for aneuploidy basically is the mitochondrial and metabolic disease, and that is age related. So maybe that's why the aneuploidy, we are just focusing on the aneuploidy rate, and that's why the aneuploidy rate is lower, even though the reserve is less. So basically what we are trying to say is that in a younger population, just don't go by the AMH values. You have to give them a fair chance, and they do stand a chance. But if the age is more, then probably even AMH at a 41 years, same AMH at 35 and 41 would have totally different mean. That's what they're trying to.
Yeah, that's what they're trying to say. And what I'm trying to say is that 36 is old for us, not for them.
Yeah.
That's what I'm trying to say. Because basically we are different, So this result, okay, we cannot say that it is necessarily going to be the same in the same age group. If we are looking at 36, we may not find the same result. But of course, yes, if we have younger girls, maybe suppose because we have so many women who are now reporting to us with 29 and 30 on DOR, no? So in some patients also, you may find such patients, even if you get one embryo or one blastocyst, that blastocyst will be euploid. That is what we need to understand. The quality is good, even though the quantity is bad, the quality is good. That is the inference from this study.
Might be good, yes.
Yeah. Ethnicity has got a great role. Yeah, we can definitely say. Even
Any
though
other
when we
observation? Any other observation? What is propensity score, beta? You must have seen this. I don't know this term.
Yes, ma'am. I read it for the first time because of this article.
Yeah.
It is like they told when we have to compare the study and the control group.
Yes.
Her voice breakdown.
We lost her.
Ranya?
Yeah. We lost her. आ जाती है, कोई बात नहीं.
They use this propensity score match.
So we missed you in between. Saranya, can you please repeat what you said?
Sorry, ma'am.
We missed you in between. Your connection was not proper. So maybe can you repeat what you said?
What you were saying, Saranya, we didn't hear you actually.
She's again gone.
Saranya?
Her connection is not good. Again, not there. Yeah. Anyway.
Technology has its positive and negatives.
Of course. All right. So anyone else or any other questions or anything?
Yeah. So there was one question by Dr. Neelmara. Ma'am, the value of AMH we consider according to age specific or general value we consider for all age group?
I think we are considering general values, right, ma'am? We are not giving AMH age specific. When we take the AMH out, we give it a normal terms, but it is our interpretation. We need to remember that in a lower age group, the same AMH would have a different outcome than the higher age group.
We don't have cutoffs for AMH according to the age, especially in the Indian population. We don't have it. Therefore, we do not know what we see over here. You can see that 3.9 has been considered in AMH for the non-POR group. It's 3.9. Or in this one where they are considering POR and non-POR, it is 3.1. But in the DOR group, it was 3.9. So that means that again, but because their groups are age matched, both are 36, you can say that, if it is 3.9, then it is normal. And if it is not, then it is definitely lower. But here, majority of our patients, even non-DOR or POR, would come with 2.1 or 2 point something, never 3. We hardly ever get any 3s and 4s in our population unless they are PCO. That's what I have observed. Your comments, both of you?
Yes, ma'am. I
Yes,
agree, ma'am. Yes,
definitely.
ma'am.
So there is a difference in that. I think we are a different nation.
Ma'am, I wanted to always ask you something. Like,
Yeah.
we say a lot of things about lifestyle. We say a lot of things about alcohol, drugs, smoking, and all that. If we consider that aspect, that I think these things are more prevalent in the Western society. Still,
Absolutely.
we say, like, I believe that maybe still to that extent it is not there in India. But still, when we talk about the number of eggs and all, ours are always lesser compared to their matching population.
Yeah,
Malnutrition?
Malnutrition, that's the biggest factor. Yeah.
Essentially, we mustn't forget our genetics. We are aging earlier than them. We are aging 5 years in advance as compared to the Western population. So basically, the difference starts from there. That's what I'm saying. That if a woman comes at 36 to us, she's going to mean something different from a woman who's going at 36 to a Western clinic. A Westerner. For them, 36 is still fertile. For us, she's subfertile at 36. So that kind of a thing it's not only environment and food and all, it's basically the genetics that we have. And so don't consider just reproduction. If you look at all the other diseases that happen to women, everything
Yes.
comes in advance of 5 years or 10 years in advance as compared to the Western population. For instance, osteoporosis, for instance, heart disease, everything
Ma'am,
is.
malnutrition may be the thing
Yes,
then. Yeah.
yes, it could be that.
Rahul, can you please unmute everyone? It is a very good opportunity for everyone. Golden opportunity to ask ma'am anything unrelated even to the topic.
Okay,
If
ma'am.
you guys have, you can ask. Please unmute everyone.
It's both, ma'am, malnutrition as well as lifestyle. Suppose we
Yeah.
take donor also. If the donor is very malnutrited, lean and thin, we get very bad eggs. And if
Yes.
that donor is of the same age from good high protein diet, then we get a good eggs.
Yes, that is true.
Lifestyle, exercise, everything matter in this.
Again,
Rahul, unmute kar do please sabko.
when we talk of malnutrition and all that, again you have to remember that there is lot of obesity also in this country.
Yeah,
But
that's it.
even that is a deterrent. So
Yeah.
that also comes under malnutrition only, because after all it's a dysfunction. But again, that also can lead to different kind of outcomes in our patients. So optimal reproduction is a very important thing. We have to optimize it. If they are not already optimal, we have to optimize it. And therefore, it's very important to understand what we are facing and which is the kind of patient who is sitting in front of us.
Yeah.
Right.
Good nutrition,
Geeta still there?
lifestyle,
Geeta, your
exercise.
comments. Geeta, your comments. Geeta, your comments. Is she there? I can see her this thing name, but I don't know if she's here or not.
She was
Ma'am,
here.
Rahul needs to unmute everyone.
Rahul is not
Then, ma'am,
unmuting.
if they want to speak, ma'am, they can unmute themselves.
What about your take or your advice or your routine in practice about the aneuploid screening, PGT? If patients come after 35 years, what you will say? 35 to 40, 40 and above. Like, what is your routine and your practice?
See, now I think everybody needs to go according to the ART Act.
Yeah.
Okay. Suppose you have a girl who's young and she's had only one miscarriage, but she's concerned. You can't do a PGT on her, na, because she's young. But at
Yeah.
the same time, if you get an older person, if you have a 36 years or maybe 38 years, whatever, with absolutely just one failure, there, of course, you are justified to do a screening. So we all have to go according to the ART Act. We can't do things like this where we are doing it randomly. So according to the indication is what we are doing strictly in our center. If there is a patient who fulfills the criteria, yes, go ahead and do it. We must, we must.
After 35 years.
Yeah.
And
What is your experience?
about after 45 years, your experience, patients who come for the self-ex, what is your experience in that age? 46, 45? AMH is 0.5 even.
We
Same.
have maybe 1 or 2 pregnancies, Niru, and I can't remember really whether we have been able to give a good pregnancy rate in such a group of patients. We always try to tell them, even if we keep on doing PRPs in such patients, it seldom improves because it may give us an oocyte, but it's not going to give us a quality oocyte and a quality embryo. That is the problem. And that is something that the patients don't seem to be understanding. They keep on doing cycles and cycles, and ultimately all the embryos are aneuploidy. And so you really don't know whether you are justified in doing multiple cycles or not. That you can't, but they're all doing this at 41, 40, 42. They keep on coming again and again, collecting 1 egg, 2 egg, and that magic number of 16 has to be achieved somehow or the other. But out of that magic number, 16, you have at age 45 is what that chart tells you. You should be getting 2 euploid blastocysts if you have 16, But I do not know how much of kisme kitna dam hai ki wo 16 eggs collect kar legi, That is the biggest challenge that we are facing now.
And the last pregnancy we have heard is like at 42, not after that.
Not after that, not beyond that. Even 42, the range is the number
very
low, very low.
Yeah.
One more question by Dr. Harshita. What happens to endometrial receptivity in advanced age? Receptivity hardly have any effect. Main is the
it changes. Receptivity it is mostly pre-receptive, the endometrium.
Receptivity also does change, Niru, with age in a small subclass of patients. You will have to differentiate, when you're doing their endometrial, when you're making their endometrium, because what happens is with age, that there are atherosclerotic changes in all the vessels. So there is hardening of even the uterine vessels. And there are ultrasound studies to show that, the blood flow and the perfusion to the uterines is much less in the older patients. Not all, but in a certain group of, a couple of patients. And those are the ones who will not conceive when you even transfer the an AA grade embryo, a blastocyst into them. Those are the patients who generally don't conceive. So there is a dichotomy over there. There is so many of the gynecologists don't believe in getting perfusion studies and ultrasound for vascular studies. But the studies do tell us that because of the hardening of arteries, it does reduce the blood flow, and therefore you have problems in these patients. Otherwise, everybody would conceive. It's not the cells, it's not the basal layer or anything which is going to, having a problem. No, if your hormones are correct, nothing will happen there to the basal layer. Your spiral arterioles will grow the way they should. But the only thing is the larger vessels are not as good as that. So that is the difference.
Hello, ma'am.
The paper, I forget the paper, but it is from Kurzok's. It's in Kurzok's book, from that book, ultrasound book from Croatia. He emphasizes a lot on this. Yeah.
And one more question by Dr. Seema Nishad. Any cutoff FSH level for POR patients?
Well, if you look at the menopause papers, anything above 10 is considered to be, it is a alarm bell for you. 15 is where in IVF centers, 15 is where we look at problems happening to our patients and we don't get a good response at all. But perimenopause is at 25 and 40 is menopause. So that is the cutoff. Those are the cutoff lines. But for IVF, after 10, we are a little wary. But we do take patients up to 15. That's what we do, all of us. But by and large, you shouldn't expect a very good result when you have an FSH of 15. Yeah.
Hello, ma'am. I have to ask one question, ma'am. Ma'am,
Yeah.
when we consider the NICS versus PGT, ma'am, what are the indications when we consider PGT, and on the other hand we consider NICS, ma'am? Because in IVF cycle sometimes we are doing PGT and sometimes we are consider for NICS. So ma'am, when we have to consider the PGT A and when we have to consider go for NICS, ma'am?
when you have to fox the ART Act, you can do the NICS because it's not mentioned in the ART Act, so you can go ahead and do it for your patient. That is the only thing that I can answer, because basically what I feel is we are still struggling with all these non-invasive tests, and you should not believe the labs because we do not know what they are doing and what is happening over there. We've had a very bad mishap with one of our patients who was reported normal on the non-invasive test, and then she turned out to be Downs. So therefore, be very careful when you're doing it. Don't get into that thing. It's much more reliable to do a PGTA rather than doing that. This is my take on it,
Yeah,
because
definitely,
you
ma'am.
do not know the
Great
you do not
experience.
know the credibility of all these new labs that are coming up, and therefore if you're just going by what they are saying, do not believe them, because at the end of the day you are answerable. The patient is going to catch you, not them. So be careful of what you are ordering for these patients.
Same, ma'am. Same experience.
So that is very difficult. It's very dicey.
On the other hand, you might be losing some good embryos also with the
Absolutely.
negative
Yes,
report.
with a negative report. Well, yes, that again, so you really don't know where you are with these new tests. Until and unless they have proven themselves, we shouldn't be believing them. We shouldn't.
Any other questions? Anyone want to ask any other query? Ma'am, you want to give any your input, advice, anything in the last?
So like I have always, see, I'm always stressing on ethics and honesty and transparency. I'm always doing that whenever I speak, because ultimately when the person sitting in front of you could be your sister, she could be your daughter, she could be anybody, somebody who's, think of the person as somebody like that. And then you see what you would do for them, if you were to order any kind of test. So be honest to yourself and be honest to the patient who's sitting in front of you. Do only things which are relevant and don't go overboard just because there's a new test available and just because you want to prove yourself as better than the other person. That is why, we are getting into this one rat race of doing one test after the other, because we want to prove that we are better than the other person. But that is something which should be taken with a pinch of salt, because we are not very clear in what is happening exactly. And somehow or the other, it's not just us, the clinicians, we are very thorough. We are very good in what we are doing. Even the drugs are to be blamed when you're talking about embryos. Sometime you will get a good lot of embryos because your drug protocol the drug use was good and the protocol was perfect. But on the other, in another month, the same drug will not give you the same results. So that thing also you must keep in mind and be very vigilant with what you're using, so that you are not blamed for anything that has gone wrong with the patient.
Ma'am, one last question bus by
Yeah.
Dr. Harshita. How to decide between doing PGT-A or transferring whatever embryo we have in case of patients who have less number of embryos?
First of all, you should have asked me whether we should be going to blastocyst stage or just transferring them at day 3. That should be a more important and a controversial question, because what is happening is we are getting 1 or 2 embryos and then we do not know whether they are going to reach blastocyst stage or not, and how are we going to biopsy them. So the answer to that is that the most of the studies are now pointing towards the fact that even day 3 embryos in patients with POR or DOR are very good, and you can just transfer a day 3 embryo rather than taking it into that if you're not contemplating doing a biopsy. However, if you are wanting to do or if it is indicated to do a biopsy in such a patient, then whatever it is, you have to take the embryo to day 5, whether there is any embryo left over there or not. You have to counsel your patient extremely well and explain all this to them that, I'm taking your embryos to day 5, but I don't know if you'll have anything left for transfer. And I do not know whether your embryo is normal or not. So that thing has to be drilled into their head. And then you can go and do whatever you want to. But that's how you decide. Always leave the choice to the patient. Explain everything, tell them the truth, tell them what is there in front of them. The patient has a tendency to blame the doctor for anything that happens to them. But they tend to forget that they have actually some kind of a disease which has led to this state. And that they have to accept, which is very difficult for them to accept. And you have to be a very good counselor to bring that point home to them and tell them that, okay, look at yourself. You wouldn't have been in this position if there wasn't anything wrong with you. So believe that as well when we are telling you. So that is how you have to counsel them.
Ma'am, the most important thing I think here is that whenever you are suffering from any disease, you actually have some kind of symptoms. You have some fever, if you have fever, whatever. If you have some disease, you have some symptom. Infertility is the only one where you are totally healthy. Only your mind is suffering and you don't realize that your mind is suffering that much. So people find it very hard to accept that, I have some disease or I am not well or something. You very correctly said that we need to tell them, but at the same point of time we have to be very gentle about it, because they are they all are so stressed that they don't take a second in. Yeah.
No, again, taking this further. So if you tell them, oh, you've got very nice, everything went off well, your pickup went off,
Yes.
we got a good egg, we got good eggs, and then at the end of it you say that the embryo was not good, then they'll say कि अच्छा आपने बोला था कि ये तो ऐसा नहीं है, अब ऐसे कैसे बोल दिया, So you have to counter that by saying कि तुम्हारी शक्ल से तो नहीं लगता कि तुम infertile हो, पर तुम हो ना, अब वो इसको कैसे explain करें? So you have to get back to them somehow and tell them, okay, bhai, मैं ही नहीं, तुम भी हो, you are also there. So that is how you'll we see. That is why it is very nice and very good that IFS has started these counseling sessions.
Program.
Yeah, and that SIG group is doing extremely well, because basically it's all counseling. If you're a good counselor, you're a good doctor in infertility. You could be having good results, but results do not mean anything. The patient retention also is important. If a failed patient comes back to you, you're a successful doctor. Otherwise, you not, because if the patient goes away to another person, then you've lost the game. है ना?
Yes, sir.
वो भी करना ही है, क्योंकि अब तो सारे फेलियर ही आ रहे हैं हम सारों के पास, कभी एक के पास, कभी दूसरे के पास. सो यही है. ठीक है.
ठीक है, ma'am.
Thank you very much, ma'am. Thank you for your wonderful inputs and all your advice.
Thank you so much.
Saranga has also done a good job.
Yeah, very good job.
Thank you, ma'am. Thank you so much for giving us your valuable advice. And thank
Congratulations.
you, IFS, for giving us this platform. Thank you, ma'am. Good night. Have a good night.
Congratulations to all of you, and well done, Saranya, once again.
Thank
Well
you.
done. Okay.
Thank you, ma'am. Thank
God-
you, everyone.
God bless everybody. Bye-bye. Have a good weekend. Have a good weekend.
Yeah, thank you.
Bye-bye.
Okay, right.